Welcome to The Explainer. Today we're jumping into one of the most challenging and honestly one of the most important areas of nursing, how we care for a patient at the end of their life. We're going to break down everything from the physiology of what's happening in the body to the legal rules you absolutely have to follow and the human side of providing dignity when it matters most.
All right, let's just dive right in with a huge question, one that every single nurse has to be ready for. The moment a patient's heart stops, your brain has to switch gears instantly. It's not just about what you were doing before they died, it's about a whole new set of priorities that kick in after. And believe me, what you do in those first few moments has massive legal and emotional consequences.
So before we can even talk about the moment of death, we have to back up and understand the journey that gets a patient there. And that starts with two core philosophies of care. Getting these two mixed up is a super common trap on exams, but in real life, knowing the difference is absolutely vital for your patient.
Now this right here is the distinction that trips so many people up. I want you to burn this into your brain. Palliative care is not giving up. Think of it as comfort care. It's all about managing symptoms, pain, nausea, shortness of breath, and you can do it at any stage of a serious illness, even while someone is getting aggressive chemo or radiation to try and cure them. It's all about quality of life. And this table just lays it all out so clearly. Look at the timing. Palliative care can start the day of diagnosis. Hospice, on the other hand, well, that's different. It requires a doctor to say, I believe life expectancy is 6 months or less. And here's the absolute game changer. With hospice, all attempts to cure the disease stop. The entire team focus pivots from fighting the disease to making sure the person's final months are as comfortable, peaceful, and dignified as possible.
And this idea of the patient's journey flows right into our next topic, grief. Because you're not just caring for the patient, you're caring for their family. But here's the thing, not all grief looks the same. Some types are really high risk, and they can show up in some pretty dangerous, hidden ways.
One of the most important things you've got to be able to spot is something called masked grief. This is where the body starts screaming the pain that the mind won't acknowledge. These people aren't faking it. They have very real physical symptoms, crushing headaches, a racing heart, terrible heartburn, but they have no idea that the root cause is an emotional loss they haven't processed.
Let's just map this out like we're drawing it on a whiteboard. It's basically a three-step process. First, you've got the unresolved loss. Step 2, because that emotion is buried, it kicks the body into a state of chronic stress. That fight or flight response is just always on. And finally, step 3, that constant stress starts to break things down, and it shows up as real physical illness. Your job as a nurse is to be the detective who connects those dots.
So your job here is absolutely crucial. You have to assess for these specific types of complicated grief. And I want you to look closely at exaggerated grief. See how it can involve self-destructive behavior? That means you have to be thinking about a high risk for suicide. That makes it your #1 safety priority. Recognizing these patterns isn't just about being nice, it is a life-saving intervention.
Okay, now we're going to walk through the actual physiology of what happens when the body begins to shut down. I really want you to create a mental movie of this, system by system. Because if you understand this process, you can anticipate what your patient needs. And just as important, you can explain what's happening to a terrified family.
So first, the heart starts to slow down. It just doesn't beat as strongly. And the body, in its incredible wisdom, starts to pull blood away from the hands and feet to save it for the vital organs, the brain, the heart, the lungs. And when that happens, you see this kind of lacy, purple, blotchy pattern on the skin. That's called mottling, and it's a classic sign that death is getting close.
Next up is breathing. As the muscles get weaker, the person can't cough or swallow like they used to. So secretions start to pool in the back of their throat, and with every breath, it creates this rattling sound. We call it the death rattle. You'll also see this really distinct breathing pattern called Cheyne-Stokes. It's a period of no breathing at all, followed by a series of really fast, deep breaths. It happens because the brain's breathing center is being starved of oxygen, so it's kind of like it's trying to reboot itself over and over again.
Okay, this is a huge one. One of the biggest things you'll have to teach families about is food and water. They see their loved one not eating, and their first instinct is they're starving to death. You have to gently but very clearly explain the physiology. The GI tract is shutting down. It physically cannot absorb nutrients anymore. Forcing food or fluids at this point doesn't help. It actually causes pain, bloating, and can make breathing even harder. You're causing harm, not helping. This table is basically your cheat sheet.
It summarizes all those key signs you're going to be assessing for in those last hours or days. From sleeping more and more to the jaw becoming slack. When you know these signs, you can look a family in the eye and say, this is expected, this is the body's natural process. And that is a huge comfort.
And then it happens. The patient dies. And in that exact moment, your priorities shift, like a switch has been flipped. You're no longer focused on preserving life. Now it is all about preserving dignity and following some very strict, very serious legal rules.
Listen closely, because the law on this is crystal clear. As the bedside nurse, you do not ask the family about organ donation, period. Your legal responsibility is to notify the specialist, usually a transplant coordinator from an organ procurement organization. They are the experts trained to have that incredibly sensitive conversation. Your only job is to make the phone call. You do not make the request.
Now, for your own legal protection, this rule is non-negotiable. If there's going to be an autopsy, you do not remove anything. Not the IV lines, not the Foley catheter, not the breathing tube, nothing. I know it can look messy to the family, but pulling those lines could destroy critical evidence that the medical examiner needs.
So when is an autopsy mandatory? Well, if there's any suspicion of homicide, suicide, or an accident. Also, a big one to remember is any death that happens within 24 hours of being admitted to the hospital. In those cases, you have to think of the body as a piece of evidence. The tubes and lines tell the story of what was happening right at the end, and removing them is like tampering with a crime scene.
And here's where physiology and dignity come together perfectly. This is one of your first priorities. Why? Well, once the heart stops, gravity takes over. Blood starts to settle in the lowest parts of the body. If the person is lying flat, that blood pools in their face, causing this dark purple discoloration. By simply raising the head of the bed, you prevent that from happening, and you give the family a chance to see their loved one looking peaceful and natural. It's a small act with a huge impact.
Okay, wow, we have covered a lot of ground. So let's pull it all together and do a quick, high-yield recap of the absolute must-know, most tested concepts we've talked about.
This is it, your final review. If you remember nothing else, remember these 4 things. 1. With complicated grief, your priority is assessing for suicide risk. 2. Palliative care can happen alongside a cure. Hospice is for when the cure is no longer the goal. 3. At the end of life, don't force-feed. It causes pain. 4. If an autopsy is ordered, do not, under any circumstances, remove tubes or lines. These are the absolute pillars of safe and legal end-of-life care. And that really brings us to our final question, which I think sums up this entire topic. Your role at the end of a person's life is this incredible, delicate balancing act. On one hand, you're providing compassionate, deeply human care to honor the person. And on the other, you're upholding strict legal and scientific precision to protect evidence and patient safety. It is without a doubt one of the greatest challenges and also one of the greatest privileges of being a nurse.